Good morning, members of the Health and Wellbeing Board and members of the public watching via platforms or YouTube. Welcome to the meeting. I've just ascertained that we are quorate, so we will begin the meeting. And I move to item 1 on the agenda, which is apologies for absence. Andrea?
We have apologies from Rhiannon Kirk, ACC Rhiannon Kirk. We have apologies from the Chief Fire Officer, so Donna Potts is representing him for the first hour. She will have to leave after that. We have apologies from Keith Gerard from Stroud District Council, and Emma Keating-Clark is here representing him today. And just to inform you, Chair, that the Deputy Police and Crime Commissioner will have to leave at 20 to 12.
Thank you very much, Andrea. Okay, if we move to item 2 on the agenda, which is declarations of interest. We have no additional declarations of interest. Members of the council are obliged to declare their interests in a public format, and they're available to the public. We have no additional declarations of interest. No one's indicating. So we move on to item 3, which are minutes of the previous meeting. Andrea, do you want me to go through that? You're down as doing that.
It's just really a case of whether the board accepts that they are an accurate record of the meeting, really,
Okay.
at this point, Chair.
Thank you very much, Andrea, for clarification. So item 3, minutes of the previous meetings. Can I ask members of the board if they're content that this is an accurate record? Can't see anyone in dissent. Andrea, have you got a better view of the screens? Anybody indicating that they don't agree they're an accurate account?
You're on mute, Andrea.
On mute, Andrea. I can't hear you.
Oh, blimey. Sorry. All I can see is a row of contented faces, so I think we should take that as it's fine.
I'm very glad to hear it. So we'll take those as an accurate record for the meeting of the 22nd of September. If we look at, could I just ask if there are any points of action on that, Andrea? I haven't been able to see any that aren't covered in the meeting today.
No, we're good to go on that, Chair. There are no outstanding actions from those minutes.
Thank you very much. Sorry, I'm getting quite a lot of interference. So if we could move on then to item 4 on the agenda, which is public questions. And I understand that we have 2.
Yes, we have questions from Bren McInnery and Councillor David Willingham, Chair. Bren's question came in first. So okay. We go to Bren first.
Thank you very much. Bren, could I invite you to pose your question, please?
Thank you, Carol Rayleigh, and I believe I'm unmuted, so I've done one good thing to start with, I hope. So my question is, what I have observed an increase focused on inequalities that has always been present and evident in the county over many years, and welcoming the present focus on addressing inequalities. What specific measures are in place now and may be used in the future to be assured and assure people in communities who have or experienced these inequalities for decades that a positive and measurable impact is being made now and for the future? My question is specifically focusing on a response to the measures, impact and assurance on addressing inequalities in Gloucestershire. Thank you, Carol.
Thank you very much for your question, Bren. I think Sue Weaver has offered a response to you.
Yeah, we've sent the response already, Carol. They've been published, the responses to both questions. I don't know, I'm assuming, Bren, you've seen the responses?
Yes, Sarah, I have read. I've seen the responses on. I've read them through 3 times now.
So, Bren, do you have a supplementary question?
Yeah, my well, I think it's a supplementary question, and I'll pose it in the way I think it's a question. Is that I welcome the response, and I think there's a lot of detail in there. What I'm still a little bit concerned about in terms of the response is that I think there's a lot more work to be done on the measures, if I'm honest. I think it covers a number of areas, and it covers a lot of interventions that we're doing and going forward. And I really welcome the panel as well, setting up the panel. But when I looked through the responses and also the papers today, and particularly Appendix 1, what I didn't see in that was any risk management. So what are the risks of not achieving that? Didn't see anything on housing, didn't see anything on intersectionality. And if we look at the NHS England 2020 report by the lead at NHS England, it's very clear on that really. So I welcome the responses. I welcome the spirit in which the responses were given as well. And that's important for me to say. But I didn't get a whole absolute assurance that we're there on the measures yet, really. I do actually thank the team, and I do thank everybody on this Zoom call and all the teams that are working absolutely flat out for the good and benefit of the people in Gloucestershire. And I'm certainly very assured that we're in a better place than we were before. Thank you, Chair, and thanks to everyone.
Thank you very much, Bren, for your supplementary question. I would take the opportunity to agree with you that more work needs to be done. And my feeling about this is that the work of the panel and the reference document that will inform what the panel does can indeed be a bit more detailed than it is, and will be more detailed. So it's an opportunity for us to actually look more specifically at issues like risk management, at the detail of how to engage local communities in actually informing the process. So I thank you for your initial question. I thank you for your supplementary, and please be reassured that this board will dive down very specifically into detail. Thank you very much.
Thank you, Carol. Thank you, Chair. And obviously I'll help where I can from the peripherals as well.
Thank you for the offer. Thank you. Andrew, I understand there's a second member of the public who wants to ask a question. Yes,
that's Councillor David Willingham from Cheltenham Borough Council.
So
David has already had the answer to his question.
David, are you on the call?
I am, Chair.
Thank you very much. You've asked your question. Do you wish to read it to us? No,
I'm more than happy to take the answer as read. To thank Sarah Scott for the answer, and I would very happily and be very grateful to take up the offer of being put in touch with the Cheltenham hub of Change Go Live, which I believe is actually in the ward I represent. But I do have a supplementary, really for the whole board to think about. So when you look at the list of what I've described, this isn't just a Cheltenham issue. This is going to affect all of us. And we've just heard the previous questioner talk about sort of health inequalities. The street drinkers and the people that are causing this problem are some of the most difficult to reach people, because of where they are engaging in their substance abuse and when they are engaging in their substance abuse. And the things that terrify me are a child or a member of the public coming across either an uncovered syringe and getting hepatitis or HIV, or someone discovering the remnants of fentanyl, and the consequences of that, or us just turning up and finding someone that has sadly passed. What I would ask the committee and the board to think about is how we get a holistic, multi-agency approach of dealing with these things which happen at very difficult times in difficult to access places, because ultimately at the moment, all we can do as Cheltenham Borough Council is clear up the litter, which doesn't solve the problem, and look at designing out the crime and the antisocial behaviour, which is just sort of changing the vegetation and what have you. And all this does, and there's clear evidence of it, it just moves the antisocial behaviour issues elsewhere. And unless we find a way of engaging with and trying to help these people, this problem isn't going to go away. You've heard all about the health inequalities. I would just urge everybody to think about how we do this in partnership, because no one agency can solve it on their own.
Thank you.
I'd just be really interested in what people think about that.
Thank you very much, David. Your points are very well made. I would just add that this group of individuals are some of the most vulnerable in our community, and it does demand a whole agency approach to them. So I thank you very much for your initial question. I thank you for your comments, and please be assured that this committee sees this issue as very significant, and as part of our ongoing 7 priorities, this is one of the things that we've included that we'll be working on very definitely. And certainly the panel of individuals that will be working with the terms of reference will pick up on these issues. So thank you very much for your input. Very much appreciated. Thank you. Andrew, I think, committee members, I think that's the 2 public questions that we've had submitted to us with answers. So we'll now move on to any members' questions at 5, Andrea?
We have not received any questions from any members, Chair.
Thank you very much, Andrea. So we move on to item 6 on the agenda, which is the White Paper, Integration and Innovation, Working Together to Improve Health and Social Care for All. This is a presentation from Mary Hutton.
Yes, thank you, Chair. I shall endeavour to share my slides. Okay, is that now clear to members? Can
yeah
see it clearly? Yes. Okay, so thank you. What I want to do today is to talk through the future plans for integrated care systems. There was a board paper sent out by NHS England and Improvement in the autumn, which set out an intention to instigate change and to look at a future statutory integrated care system. That followed by a period of engagement, and following that period of engagement, we then had the white paper, which sets out the aims and some intentions for future legislation. And that's what I want to go through now, and then hopefully take questions if people have particular questions, and I'll see if I or other colleagues can answer those. So the aims for future legislation fit very closely with the aims that we already have in place in Gloucestershire. So this is not a significant move off track for Gloucestershire. So they talk about stronger partnerships in local places between the NHS, local government and others, and a more central role for primary care. They talk a lot about provider organisations and the idea of collaborative systems across provider organisations to enable operation at scale. We're still working through what that might mean for the Southwest, because we are very different than some of the urban centres that are working on provider collaboratives. And also strategic commissioning, really focusing on population health outcomes and ensuring that we're holding up a mirror to our systems and using digital and data. So I don't think that is very, very significantly different than the intentions we had set out in Gloucestershire. The 4 fundamental purposes are about improving population health and healthcare, tackling unequal outcomes, and then enhancing productivity and value for money. And also, this is a very big new intention, which is to be driven quite hard. So helping the NHS to support broader social and economic development. And that's something that we've been thinking about with the County Council, and it will move more to centre stage, we hope, in the work we've planned already starting this year. So we have been working, as you'll hear later on a different agenda item very closely already with our local communities. So decisions taken closer to communities, and we agree that absolutely we want to centre people in their communities and to work with those communities. And also this partnership, a place where people own the population together. And we've been operating at the moment with our places around our district boundaries and understanding how do we take the resources at place and get the most out of them for our population, and also that collaboration between providers. So there has been some early thinking set out around the ICS structure. There are some very different sizes and scale of ICSs across the country. For some of the very larger ICSs, they have been thinking about this dual model where you have an ICS NHS board and an ICS Health and Care Partnership Board. We will have to think through in Gloucestershire what is the best structure for us in Gloucestershire so that we can meet the needs of both the ICS NHS Board and the Health and Care Partnership. They're working at the moment on the legislation in more detail, and they're also working on guidance, and I'll explain in a moment how we're involved in that. But they haven't, they're trying to be as permissive as possible and set out as little rules and regulations as possible so we can determine locally what actually fits the systems that we are representing. We have begun to think through in Gloucestershire what are the principles which will underpin our approach as we move forward, because we will have to think through what the future design of our integrated care system going forward will look like. So these are the principles we have put together. I'm not going to go through all of them, but I think it's essential, the beginning ones where we said population staff are at the heart of all we do. And I think it's really benefited us in Gloucestershire to think through that we're all serving the same population. And that's been really useful as we've been planning for the last couple of years. And of course, we don't want to have function determining what we do, but we want to really be outcome focused. And also we are hoping that there will be some room for local decision making so that you can actually meet the needs of the different sizes and scale of ICS. We've said that we want to keep the grit the commissioning can bring to our system. We need to work out how that would happen. And also we are hoping that as we work together further, we can take out duplication and deliver our best value. And we're trying to think about how we do that by looking at how people pull together resource. We also have strong clinical and lay public participation, and we've really learned, certainly during COVID, how we actually can pull in many more people using virtual means, and we'd want to build on that. And also, as we've been doing already around programme work, making sure that there is a consistent offer across Gloucestershire. It may be delivered slightly differently, but there's the same quality standards. So we've been thinking about how we build on the successes and learning we have in place already. So first and foremost, we're saying that we want to really maintain and build on the Health and Social Care Partnership, and that includes our work with children's services, and also the look at how we develop the model of working together and ensure innovation is central to that model. We also want to think about how do we move faster, make decisions faster. We believe that at place it will be possible to move more quickly, make faster decisions, but also we have a huge amount of experience developed on our clinical programmes and programme budgeting. We've started to think that through. How can we actually really ensure that we spend more of our resource on the front end, on the prevention, and ensure that our model really is beginning to target more the early intervention in people's care. And we have got started some thinking about learning from the rapid achievement. The more examples have been added all the time. So we've got the virtual ward, we've got the vaccination programme. We've also got our silver linings from COVID work, and we'll continue to try and distill from all of those examples what our learning is. And then we want to build on that for future model of working. And what I suppose we've talked through is that the reason Gloucestershire has been able to move forward and to deliver a substantial amount of change is that we have trusted relationships, and we want to ensure that we don't lose any of those trusted relationships but build on those. And also we're thinking more and more about the wider determinants of health, the voluntary sector, housing, education, children's services, etc. We've got some good pilots now with respiratory, for example, housing in Gloucester City, and lots more examples across the county. And we realise that we want to be working with partners to really recognise the individual person's need and understand how the whole system can meet that need. So this subsidiarity idea, there are some new potential offers to Gloucestershire. There's a suggestion that direct commissioning, which is currently done by the NHS England team, will be available for ICSs to take some responsibility for. So that might be dentistry, optometry and other services, and also specialist commissioning. We need to decide how we operate around specialist commissioning. So that's quite a substantial resource for our population. And there are some elements of specialist commissioning that we believe could be actually joined into our well-developed pathways now, rather than sitting very separately. So we're thinking about partner collaboration with other ICSs around elements of specialist commissioning, and that's something that will be worked through in the next couple of months. And we'll then compare what we're doing to other areas to understand that we get the best system set up for Gloucestershire and for the Southwest. And indeed, we will have to participate in some other areas around us, because some patients go to Oxford, etc. And PCNs, you know, how do PCNs work best with neighbourhoods? How is place developed, and how do other resources that currently exist at those places work best together? And then how do we ensure the right support exists at each level? And of course, data and analysis will play a huge part. And we're thinking about that whole benefit of pathway working at scale. So this all will not have to be developed until we get more clarity on the legislation, and also we'll see more of the guidance. But we're expecting this to be work around May, June time in our system. So the next steps, the ICS board is acting as a sponsor group, and colleagues here, some colleagues are obviously on the ICS board, and focusing in on those system design principles. And we've been very pleased to be nominated as a test system with 8 other systems nationally, and that means we get an opportunity to look at the legislation and the guidance as it develops, and to input into that alongside other systems. We realise this is an opportunity, and we're trying to ensure we have enough resources to take that opportunity. We also will work with other parts of the Southwest in terms of looking at areas of development. We are working again, as I said previously, on ensuring that we have the right resources in place, and ensuring that we understand for Gloucestershire and indeed within the Southwest, how does this emerging policy and guidance work, and how can we best influence it to get the best results for our system. And then we're beginning that mapping of a transition plan to the future. So let me stop sharing there. So I think for us, in summary, we think this direction of travel fits very well with the direction of travel that we were already engaged with in Gloucestershire, but we know that there always is challenge, so we need to focus in on the detail to ensure that we get the best outcome for Gloucestershire.
Thank you very much, Mary. Very comprehensive briefing there. For me, this work seems to be almost familiar now, because we've been working on it for quite some time. And with all the demands of COVID, it's given us some opportunities to change things, because we've actually had to, under duress, really. So the learnings from COVID, the good learnings, so I'm glad we're able to actually incorporate into some sort of planning process. I'd like to open it up to the floor for any comment.
Chair, Peter Williams, Nikki Richardson and Sarah Scott have raised their hands.
Thank you. Could we go in that order then? I will go with Peter Williams first.
Thank you, Chair. And mine's just a question, really, in terms of that working across boundaries bit. How are we going to integrate with the Welsh side of the border, which is it's quite important to the forest population, where some of them derive some of their services from Wales?
Yes, I can answer. We have a really big challenge there, as you know, that the funding goes directly for the residents who are registered with Welsh GPs directly to the Welsh Government, and those services are provided. We are constantly working with residents from that area to identify issues, and there is a national meeting then that we attend to try to resolve those issues. I expect that will continue, but I don't anticipate at this stage any change of that funding arrangement. But we will need to keep that under review. It is quite complex, and there are a lot of issues that continuously arise, and we had lots of issues during the vaccination programme that we had to work through, but all of those were able to be worked through by people focusing some time and attention.
Thank you.
Thank you, Mary. I think the next one I have is Nikki.
Hi, thank you. Morning, everyone. Thanks for a great presentation, Mary. You touched on this in your presentation, but I just wonder if you're in a position to add a bit more detail as to how the public voice and experience is going to be at the heart of the ICS decision making and service provision. It may be work in progress, but actually how that work in progress is an engaged process would also be of great interest.
Yes, so this is quite early stages. At this stage, NHS England and Improvement have been leading the engagement on the future plans for integrated care systems, and we will start working on our own public engagement as we work through, once we have seen the legislation, understood it. So that's something that will be part of our transition plan, and that isn't developed yet because at this stage we haven't had the formal go-ahead and understand what it means for us in our system. I think we're expecting that in the next month or so. So that will be developed. I'm happy to come back and talk about that again at this meeting.
Thank you, Mary. Thank you for your question, Nikki. Sarah.
Thank you. I suppose just a comment really. In the white paper, it talks about the creation of two ICS boards, one of which will be a broader partnership board, which will have a plan to look at healthcare and public health priorities for the population. And there are a lot of similarities between that and the Royal Health and Wellbeing Board. And I think we just need to be open to the fact that we've got a new health and wellbeing strategy, but there's more than enough need and more than enough work for us all to do. So I think just to reflect the comments I've had, discussions I've had with Mary and Jill Morgan, the ICS chair, around we'll find a way through this that will hopefully not mean duplication of effort, but will mean improved outcomes for our population, which is our main focus, isn't it? And taking the best of the health and wellbeing strategy and whatever we need to create as an ICS as well. But just to offer a bit of assurance there, in case you haven't picked up that detail. But I think that there's enough work for us all to do.
Thank you. Andrea, do we have any more indication of people wanting to speak?
No more hands raised, Chair.
Okay. Thank you very much, Mary. I think it's very much a work in process. I just wondered if we'd actually have a time scale for this, because there's some anticipation of guidelines coming fairly soon.
Well, we know that the implementation date is April 22. So if we work back from that, there will be quite a tight timescale. But we are not expecting, we haven't got the actual final detail of that yet.
Thank you very much, Mary. That's good to have something to think about in terms of where we're going with this and how we need to plan the way forward. Thank you very much. No one else wanting to speak on this issue? No. Just my thanks for the presentation, Mary. It's certainly very clear and offers food for thought that we can actually feed back and actually work on. So thank you very much. We can move on to item 7 on the agenda, which is Director of Public Health Annual Report Beyond COVID, Race, Health and Inequality in Gloucestershire. And that's for Sarah.
Thank you, Chair. Just trying to share my screen. It worked in practice. Can you all see that? Yeah. Okay. So thank you for the opportunity to present my annual report. This is my 5th annual report since being appointed as your Director of Public Health. And an apology, I usually co-present with Althea Lynn, who's the co-chair of the Gloucestershire County Council Black Workers Network, but unfortunately she's unable to join us today. So this is our 5th annual report for Gloucestershire, and as usual it has a theme of tackling inequalities, and we usually choose a subset of tackling inequalities to try and hone in on something helpful and hold a mirror up to the system. And we were doubtful we'd have capacity to write an annual report this year with them helping to lead the response to COVID locally. But what we began to see in April and May was a disproportionate effect on certain parts of our community across the country, and it became clear that ethnicity was playing a significant role in outcomes in terms of COVID. And coupled with that, PHE produced a couple of really helpful reports in June, and we were beginning to see some useful literature and evidence around what we could do to tackle inequalities associated with COVID. And then in the summer, we saw the Black Lives Matter social movement as well. And I think it really gave us a brilliant platform to shine a light on the inequalities associated with race and health and inequality. We became really aware in public health that we are an all-white SLT, and that we wanted to write a report that was credible, that had meaning, and resonated with all parts of our community. So we were really pleased when our Black Workers Network agreed to co-author the report with us, and hence why Althea is normally doing a double act with me here. Unfortunately, she can't join us. So I'm just going to take you through this report. You've had the report in your pack. Some of you would have seen this presentation in other meetings I've attended over the last 6 months. We published this in October. So the first slide is a quick overview of inequalities. I know you've heard me speak about this a lot. I won't dwell on this. You all know what inequalities are, and you know that we need
Sarah,
to be able
could I just interrupt for a moment? There's been a request that you make the screen bigger. People are having difficulty reading it.
It's big on my screen. I'm not quite sure why that's not doing it.
I've got 2 slides on at the same time.
Chair, on the left of people's screens, they may have the option to actually enlarge. Oh, Sarah's sorted it. That's okay.
Yeah.
Is that better?
Yes, thank you.
Right, okay. I'm not quite sure how I'm going to... Right, that's fine. Okay, apologies. We said it would be a bit shoddy today, so apologies with my use of technology. Okay, so I hope you can see that now. So in the report, it talks about inequalities, and you've heard me talk about these a lot, so I'm not going to dwell on this slide, but I think what COVID has done is really shone a light on how inequalities are still persistent within our community, and they would have widened as a result of COVID. So in the report, we talked about some key determinants of health. We looked at education, housing and employment as a way to try and explain how we see differences in between different ethnic groups. And what you can see there in the graph is a difference in educational attainment between groups of pupils from different ethnic backgrounds. And there's a real stark difference as you get towards GCSE and attainment 8 level. And this is in Gloucestershire, where we have predominantly really good schools. And so it's still that unjust and embedded and unfair difference that we're seeing in our population. And we know, because we've brought in reports on this before, that it's so important to have the best start in life, because that is a large predictor of your future, and education is so important. We also found inequalities in relation to housing and unemployment as well. So, as I said, in April and May, we began to get really disturbing reports of different ethnic groups being affected disproportionately by COVID. And we found that Asian, Black and white other ethnic groups were overrepresented in the number of positive COVID cases we were seeing across the country, but also in the county. We also found that quite a large proportion, so over 10 and over 11% here, of cases didn't have their ethnicity recorded. And when we look at our COVID data, as we do every day in my team, 7 days a week, we're still seeing around 10 to 12% of cases without ethnicity recorded. And it's really difficult then to understand the true impact of COVID. Nationally, we saw that people of Bangladeshi ethnicity had around twice the risk of death than people of white British ethnicity. And there was a 10 to 15% higher risk of death when compared to white British people. It is a significant issue to have to deal with. And I think it's really helped us understand a bit more about how COVID spreads between different communities. So the report, as always, tries to focus on some of the need and within the population, but also tries to focus on some of the strengths to excuse me. This is not, I'm not a big coughing today, but it's not new and persistent, I can assure you. And we really try to focus on community resilience because that's one of our strengths in our county. We've got a really vibrant voluntary community sector, and they have really stood up to help us and help our communities throughout COVID. And so we see some case studies throughout the report. And the next slide talks about, there's a quote here from Imran Aksha from the Friendship Cafe in Barton Treadworth in Gloucester. And it was really helpful to understand how they coped and how they'd responded and how they'd done it almost entirely without the intervention of the statutory sector, and sometimes just decided to do something to help the people around them. And there's a valuable lesson there for us in terms of that bottom-up strengths-based approach and how it doesn't always need to be commissioned or requested by the statutory sector. But what it did show is that as our BAME voluntary organisations are, they're predominantly run by unpaid volunteers, and they do tend to lack the necessary organisational infrastructure to apply for mainstream funding that can enable them to be sustainable in the longer term. And I think that it's really shown a light on the role they play in and the wealth of knowledge and experience they have, and then the agency that they have within our communities. I think there's something that we need to do to continue to ensure the sector continues to receive necessary support. And we're doing a little bit of that through the Contained Outbreak Management Fund, but that's not a sustainable source of funding. So we need to be mindful as a set of statutory organisations and as a wider community how we continue to support these organisations. So we know that the nature of BAME people's employment has been a key factor in the pandemic, and they've faced a disproportionate risk. And I should say, in terms of my use of the term BAME, we talk about this in the report, but we talked at some length with the Black Workers Network about whether we should use the term BAME or how we should reflect people's ethnicity. And we talked about it a lot, and I know the government have now come out with some guidance where we don't use the term BAME, but our Black Workers Network at the time were keen that we did, but recognising that that really represents a really rich and varied and diverse group of communities in Gloucestershire. So I should have said that in the beginning. So we know that BAME people's employment has been a key factor in the risk they face, and on the screen there you can see some quotes from Gloucestershire employees in the public sector about how they felt fearful, they felt scared, they felt worried about raising issues around their ethnicity and their workplace risk assessment. So there is a need to work with BAME employees to create that healthy and supportive workplace where we have a zero tolerance for discrimination, and we empower BAME staff to come forward and raise their concerns about occupational risk. So communication has been a huge part of our response to COVID. I certainly feel like that's where I've spent quite a lot of my time trying to push out key issues to help keep people safe. So when we found this research by the Runnymede Trust, we were quite interested in this. And whilst it only talked to 2,500 people, they talked to a really wide range of people from different ethnic backgrounds about their experiences during the pandemic and how they heard the messages that were put out nationally. And I think for me, it was quite a stark reminder of what you say and what people hear and how they hear it are very, very different. And we can see there the differences between white, British, Chinese and Bangladeshi communities in terms of what they heard with the national messaging, for example, the stay home, protect the NHS and save lives, or the message around minimum statutory sick pay starting on the first day of self-isolation. There's a real difference in how different communities heard these messages, and the barriers as well to communication in terms of fear and mistrust, digital access, cultural sensitivity and the language are all something that we've taken on board and tried to incorporate into our messaging, not only around the public health messages, but also around the vaccination messages going forward. We also learned that you were at increased risk of COVID if you had pre-existing conditions. We know that diabetes was a common one, and also excess weight. And we also know that we tend to see more diabetes in some ethnic groups. So there was a considerable risk there. I think also it was a helpful reminder in terms of how we develop services for our communities, and that one size certainly does not fit all. And there was a case study in the report about the Healthy Lifestyle Service working with a particular group, I think it was in Barton and Treadworth, to try and develop more culturally sensitive services to ensure that people were more likely to take them up. At this point, I normally hand over to Althea, and she talks about becoming a culturally competent organisation. Now, this was not a term that I was familiar with until we did the research for the annual report, and I've presented this report many times, and I've been really honest that having read the research around being culturally competent as an individual in an organisation, I think I was hovering somewhere around the middle, and I was quite surprised at that, not thinking I was a particularly racist person at all. And so I think that there is some quite helpful reflection we can all do when we read the report around cultural competence, both in terms of ourselves as members of our communities, as leaders, and then also as organisations. So cultural competence is the ability to understand, communicate with, and effectively interact with people across all cultures. And I think that this tasks individuals and organisations to examine how existing structures combine with their own understandings of the world leads them to make decisions that can possibly exclude people of colour. And we talk about bias and organisational bias as well in the report. So in response to the DPH annual report, the County Council set up a BAME COVID task and finish group looking at how we can tackle some of the recommendations in the report, but also focusing on how we can become a more culturally competent organisation. I know from other presentations I've done, certainly Stroud District Council were very interested in this concept, as were the ICS organisations. And I think the whole purpose of the DPH annual report is to spark conversation and to hold a mirror up to try and bring about some change. So the last slide talks about cooperation and co-production. And I think that I talked about unconscious bias before amongst our staff, perhaps a lack of representation of BAME people at all levels within our organisation can have a detrimental impact on access, experiences and outcomes for BAME residents in our public services. And it's not the first time that I've heard that members of the public feel done to or consulted with, but then sometimes don't see the outcome of their from their time and their input. So there's clearly still more work for us to do in terms of how we truly co-produce our services with our communities. And I think that links into our Gloucestershire way and the work we want to do around a strengths-based approach. But there's a very big difference between saying it and actually doing it. And I think that was the experience of the Black Workers Network when they were helping us write the report. So I'll just talk briefly through the recommendations. They're quite long, but we took the recommendations from the two Public Health England reports that came out in June last year, and our Black Workers Network worked with the Public Health team to assess the local evidence, and we came up with some more Gloucestershire focused recommendations. So the first one talks about collecting comprehensive and good quality ethnicity data, and this is about requiring organisations to do it. And it will involve also training staff to understand why people from a BAME background might not be willing to reveal their ethnicity. So there's something really important there, including death registration data, because it was really difficult to understand the impact on different ethnic groups, particularly who sadly died from COVID, because we just didn't have ethnicity data collected at the time of death registration. There's something that I've already mentioned about capacity and resource for research around BAME issues and working with BAME employees and organisations, because we need to understand some of the cultural, structural, economic, religious and commercial factors affecting or relating to COVID. And we need to then use this research to fund interventions that are more likely to have an impact with different ethnic groups, and recognising we're going to probably need slightly different approaches for different ethnic groups. And we need to recognise that as commissioners, as providers of services, that we will need to work differently. The third one talks about reviewing our commissioning procedures and practices in relation to equality impact assessments. We did some work in the council to look at what had happened as a result of all the equality impact assessments that we've written, and there have been many, all the decisions we've taken, and the outcome was that there was very little change, if any. So we need to make sure if we're going to go to the effort of writing these documents, they have to bring about some change. The fourth one was around a system-wide commitment to the implementation of a culturally competent occupational risk assessment tool. Now, I know the NHS have done a lot of work and stood this up very quickly last year in relation to occupational risk assessments and COVID, but I think it's about understanding how these have landed with staff, and those comments were from Gloucestershire members of staff who work in our public sector. So I think there's probably some more work still to do. And what I would say is these recommendations were written at the end of August, so work has continued throughout the autumn and winter, and things have changed. So we want to work proactively with BAME and faith community representatives to develop and distribute culturally competent prevention communication work, and we're doing this through the local resilience forum. So we're already working through the strategic recovery group underneath the local resilience forum, but we have to make sure that our communications are culturally sensitive. So we've done a lot of work in the autumn with Gloucester City Council and faith leaders and community leaders in the Barton and Treadworth area, and recognising there are lots of different ethnic groups that live in that particular part of Gloucester, but but people can live outside of Barton and Treadworth as well, and be from a whole variety of different ethnic groups. But we work very closely with the community there to try and inform some of our communications. And again, that did help in the third wave when we were experiencing very high levels of cases in Gloucester City, but also in relation to the vaccination uptake as well. Recommendation 6 was around our recovery strategies, and the Recovery Coordination Group have taken this report and are really mindful of how they consider tackling inequalities in the longer term as part of their recovery strategy. Number 7 was around undertaking stock take of funding and capacity within the BAME voluntary sector, and understand what is needed in the longer term. And as I said, we've been able to provide some additional resource via the Contained Outbreak Management Fund for the next year, but we do need a longer term sustainable funding source for this particular part of the VCS. And the last one was about establishing a race equality panel for Gloucestershire, and this was about complementing the work of Gloucester City Council, but to also drive forward this work on a longer term, but holding statutory agencies to account, because I think we can write all the reports we like, but we need to continue this. And this is a long-term piece of work, and we need to be held to account for this continued change. Since writing this report, Cheltenham Borough Council have held 2 conferences, I think it is now, around the Black Lives Matters social movement, and they've also decided to convene a type of race equality panel for Cheltenham. So I think there is still room to do some work at a county level, certainly for organisations that work at a county level, and we need to understand how we take this forward. So I'll pause there, and I'm happy to take any questions.
Thank you very much, Sarah. I've heard your presentation several times, but every time I pick up something new, because it's a lot of information to capture and to think about how that is important for me and my work as a counsellor. The notion that information and communication is important is for everybody, and it's made me really stop and think about how I communicate and what messages are actually picked up. Thank you. So I think repetition isn't a bad thing. Right. I see that Deborah wants to talk. Andrea, are you picking up anyone else before?
We also have Richard Boyles and Rob Weaver.
Could I go with Deborah first, please?
Thank you, Chair. I just wanted to ask Sarah a question in relation to the recent government guidance, and thanks to Bren McInerney, who actually brought this to my attention. So it hasn't been widely distributed, but Sarah, I'm sure you're aware about the guidance that's been issued about how we write in relation to ethnicity. It's particularly relevant to this conversation about communication. I think we have all danced around and almost struggled with some of the changes that almost came left of field. You know, we were BME, we became BAME. We're now advocating ethnic minorities as a collective term. So I just wondered, you're thinking about us as a whole system. We want to be obviously consistent in our language and respectful of what communities are telling us about the sorts of phrases and terms that they use and would like us to use. I just wondered what the council's thoughts were, or Carol, you know, the Health and Wellbeing Board's thoughts are about how we respond as a whole system to the government. It's guidance, it's obviously not policy, but how we respond to that government guidance.
I think it's a really important point, Deb, and that's why I made the point. So when we wrote this at that point in time, we all agreed that BAME was not an ideal term, but the Black Workers Network wanted to use that term in the report. Obviously, that was current at the time, but I think now we've had this new guidance, we do need a view as to what the terminology is going to be. And I think this is probably the last on the list of places to bring the annual report, so probably won't be presenting it again, and it would be accurate as it was at that point in time. But you're absolutely right, we do need a position on this, we do. And I think that's why, I'm sorry Althea isn't here, because I know she has a view on this.
Comment about the future, definitely comment about the future, not looking for any change. It just feels as though it's something that we would do well to kind of lead collectively rather than individually. Some adopt, some not. But yeah, no obvious suggestions as to where we make that decision, but just didn't want to miss the chance to raise it.
Thank you. And I wonder whether we ask some of our communities what they want us to use, because obviously we've got the Black Workers Network in the County Council. I'm sure there are similar fora in NHS organisations, but we are an entirely white British Health and Wellbeing Board. So do we need to seek some feedback from our communities to understand how they would like us to refer to them in our communications? Because it is guidance, and as I said, that might be a more helpful thing to do. I'm quite happy to take away an action to think about.
And I guess, yeah, because I think just my final reflection, Carol, on that would be that obviously in developing a national guidance document for all government departments, a lot of consultation with those communities went on, and there is perhaps a risk of too much local adaptation, because we may then end up with language that becomes confusing because we've got councils on our borders or health, NHS institutions. Is whether, I don't know, I'm just reflecting, is there merit in going local if we've done such a large piece of national work with nationally recognised representative bodies? I don't know. There'll be some benefits, won't there, of both approaches. We're trying to get an answer from the NHS as to whether they intend to adopt their own governance guidance, but we haven't had a reply yet. We'll watch this space.
It'll be interesting to hear what they say. I think my view would be that we need to make sure that everyone's got access to the guidance and can form a view, but also we need to check out locally if that guidance is actually something that local people recognise and would support. So I think we need to have two strands there. And I've just picked up from Mary that she's offering to send the guidance round to board members, and I would welcome that as a starting point. But I think this is a beginning of a conversation, and I think,
I agree.
We need to keep it high on our own agenda in terms of the Health and Wellbeing Board, but each of our organisations has got a pivotal role to play in this. So it's vitally important as we move forward.
I'm in danger of now bagging a third question in my slot, but I suppose just a final response to Sarah, of course, is she has made a really valid observation, hasn't she, about the extent to which we are representative of the communities we serve in terms of our, not just our ethnic makeup, but potentially, a number of other protected characteristics. So again, just not for now, but a thought, Carol, as to how we might want to reflect that. I don't know how we might do that. Is it positive action? Who knows? But it'd be good to just give some thought to that perhaps as well at a future date. I will stop now, I promise.
Is that yes? You can't have any more questions, Deborah. I think that's a really important issue about membership of particular groups, and I think going forward, the COVID experience has given us the opportunity to actually connect with more people, of more variety of people in our community that actually represent the population more specifically. So I think we're now in more contact with people, and we can make those invitations. So it's certainly very high on my agenda, and we'll go forward with that in the new term. Thank you, Deborah. Right, Richard.
Yeah, thanks very much, Chair. Good morning.
Morning.
Sarah, looking at number one in your recommendations, which is the comprehensive and good quality ethnicity data collection, I was certainly disappointed to see that in the report, the stats for BAME for Gloucestershire Constabulary reflect 2015. Is there no more recent data that Gloucestershire Constabulary could provide with regard to their forces reflection of the communities that they have within them as a workforce for this report? Thanks.
That was what was available to us last summer, but maybe Chris can comment on whether there's any more recent statistics available.
I'm sure there are, and I'll find out for you and feedback to the board. Thank you, Richard.
Thank you, Chris. Put that down as an action point for you. Thank you. Richard, do you have anything else to ask?
No, nothing beyond that. Thank you.
No, thank you for raising that issue, and we've got a promise from Chris for more up-to-date data. Thank you. And I can't remember who the third person was. Is it Brian?
It was Robert Weaver.
Robert.
And we also have Anna Brinkoff as well, who would like to ask a question.
And Tim.
Thank you. Robert?
Yeah, thanks, Sarah, and thanks very much for the report. What I found it all interesting, but what I found particularly interesting was the variation on the communication and how well or not so well the messages are landing within the different parts of the ethnic communities. That's really quite interesting, isn't it? And I just wondered whether there was a key criteria that stood out in terms of why, particularly among some of the Bangladeshi community, the messaging that we thought may be clear wasn't landing and wasn't getting through. What was there anything that struck you about what was leading to that discrepancy between how the communication messages were landing?
It's been some time since I read that report, to be honest, Rob, probably June last year. There's nothing that's really, nothing that springs to mind. I think it was more around knowing your communities and knowing which ethnic groups are represented in your communities and understanding how you want to communicate with them. And our learning we took from this was around that we need to go out and work with the communities. And that's what we've done, certainly from early autumn onwards, to try and understand what, and so well, actually, if we need to send a message around how to adhere to COVID safe guidance or how to promote vaccination, how do you think we could do this within your community? What do you think would work? What messages, what means of sharing the message would work? And that's been really helpful. And we've done all sorts of things that have cost very little money. Some wanted leaflets, some wanted recordings that could be shared via WhatsApp groups, some wanted them in different languages, and quite simple things. But because we asked, and I think we always thought we were asking before, but clearly we weren't, they've had an impact. And I don't know if you can correlate that with the reduction in cases in Gloucester City, which now are some of the lowest in the region, if not the country. But I really felt that we have seen a decrease in cases, and that's a really positive thing.
Brilliant. Thanks, Sarah.
Thank you, Robert. Anne?
Thank you, it's Anna. Thank you very much. And again, I think the report is really helpful. And I think the word is trust, isn't it? You know, if our communities trust us and engage with us, we can, you know, they will hear the messages we want to give as well. I just wanted to briefly reflect on the Gloucester Commission to Review Race Relations, which has been established now, and we're going to be doing a series of sort of deep dives into particular issues. But I also wanted to say that I fully support recommendation 8. I think given the nature of the organisation in the county, I think it would be really good to have a permanent, you know, panel or something which can sort of tap, you know, which can hold us to account for the actions we're taking and be our conscious in this as well, because otherwise we won't affect any long-term change. So we are very committed in the city in Gloucester, and we've worked really well, particularly with the public health team as well. But I think it would be brilliant to see something slightly broader. So I was going to ask Sarah, in terms of the recommendations, who holds them, and how do we make sure that, you know, we are either individually or collectively implementing them as well?
So I broke up a bit then. I've been having some further GCC IT issues today. I think I heard that Anna was supportive of a county-wide permanent Race Equality Council. But what was the second bit, Anna? Sorry.
I was just going to ask, in terms of the recommendations, you know, who holds them and how do we make sure that they are kind of, you know, alive, and we go back to them and make sure that we implement them?
So at the moment, I think I'm holding them, and so I think there's something about how what I wanted to do was to embed those with that Race Equality Council, and I think this report came out when we were going really well in terms of making some progress in terms of trying to implement the recommendations, and then the third wave hit, which slightly made I had to pause everything. But I've been having some really helpful conversations with the BAME COVID task group we've established in the county council. And they've done some thinking around how we could take this forward, and had a discussion at a county council corporate leadership team around how we might begin to fund a Race Equality Council, because we all need to understand that I think if we're going to make sustainable change around the issues the report's highlighted, we need to allocate some funding. I think it's going to need an independent chair, and it will need some secretariat support, and we need to be willing to fund that from the public sector. And we had this conversation too long ago. I think it was in the governing body of the CCG when Andy Seymour asked me, you know, what's your plan around this, Sarah? And I think it is about trying to find some money to set this up. But we'll come on to funding for the health and wellbeing board priorities later, and that's been really, really difficult, trying to get partner organisations to commit very small amounts of funding towards 7 priorities we've all agreed. So technically, you haven't agreed to priorities in the DPH annual report, so that I think will be even more difficult to get some funding allocated. So it might fall to one organisation to find some money. It doesn't need to be much, 50k maybe, to set this up, to have a bit of seed money to try and get some work going. And I think it will make all the difference, because it would be really easy to sit around this virtual table, nod in agreement, say thank you very much, Sarah, another great annual report, but we need to hold ourselves to account to deliver these recommendations, because I think they really will make a tangible difference. And I think that independent panel will help. So at the moment they sit with me, and I've got some discussions this week and later on this month around how we take that forward.
Thank you, Anna. Any further questions for Sarah?
We have Andy Seymour, Chair.
And Tim.
And Tim. Okay. Andy, would you like to go first?
Thanks. Well, it's probably a comment as much as a question, but it might lead on to a question, and probably links to the board in particular in terms of housing. I came across a stat which I'm sure Sarah knows and probably familiar to most people, but in terms of household occupancy and in terms of the percentage of people who have a household of more than 6 or more people in a household. And nationally, I think it's something like 2.4% from a white community, 7% in an Afro-Caribbean, but something like 26% in the Bangladeshi community. And that's clearly contributing to some of the higher COVID numbers in those groups. Yeah. And clearly, I imagine it's replicated within this county, those kind of stats. And again, therefore, it has housing implications for us as a community and as a board. So as a comment, but as I say, may lead on to other points as well.
Thank you, Andy. Sarah, did you want to come back and respond to Andy on that?
No, I think it's a point well made, Andy. I think that there's a lot of work going on around enduring transmission in other parts of the country that I don't think we've necessarily suffered from here. But we know that ethnicity and those wider inequalities have played a significant role in the transmission of COVID, and why it's so difficult to reduce levels, particularly in areas with large ethnic populations, because of some of the housing issues that you've mentioned.
I would comment that housing is one of our 7 priorities as a health and wellbeing board that we've all signed up to, and I'm aware that there's a fair amount of work going on with that. Okay, Tim.
Yeah, thank you. Again, probably a comment rather than a question. Perhaps there's a question hidden in there. I very much welcome this report, which is, after a considerable amount of work, I think it's really good. And I think it's something that will guide us as we go forwards. I do agree with Anna's point, actually. I think we do have to have, a solid, if you like, performance assessment of where we're going with a strong board that needs to come back. Sometimes we're very good at producing wonderful reports, but they don't always produce the action that we want them to. So I think what we have to demonstrate now, all of us working across everywhere, is to deliver this. And I think that if there's anything solid has come out of the pandemic, perhaps it shows that we do need this greater understanding to tackle things going forward on a number of fronts. So I very much welcome the report.
Thank you for your comments, Tim. Anyone else wanting to speak on this paper? No. I mean, from my perspective, I think the recommendations are all very sound, but they're only as valuable as actually working on them, actually intervening to make them be not recommendations, but actually parts of an ongoing strategy to enable the communities that we live in to be representative. So we do need to have further discussion on this. And the notion of an independent chairing a very specific community to actually look at this, I think is really important. So I would ask individual organisations to just think about that in terms of not only small amounts of funding, but to maintain it, but also to think about membership and how they could move this forward within their organisations. So I think we need to look very specifically at some seed funding and to get this in action in a relatively short period of time, and not lose sight of the other recommendations that Sarah and her team have so ably documented for us.
Carol,
thank you very much, Sarah.
I just wonder whether to hold me to account and to hold us to account, whether I bring back an update at the next Health and Wellbeing Board, which won't be until June in the lifetime of the new council, but to try and reflect back on some of the progress in terms of what we have and haven't been able to do. And at least then we're not losing the recommendations and we're trying to push it forward. So I'm quite happy to try and bring back an update in terms of how far we've got.
I think I think I, on behalf of the board, would welcome that, because as Deborah and others have said, this is a document done at a time of immense duress on the community, has made some profound findings and recommendations, and we need to actually review where we are with it and move on. So a paper for the June board would be an excellent idea. Thank you. So an action point there. Okay. Members, we'll move on to the next report, which is at number 8, Health Inequalities in Gloucestershire, COVID and Beyond. And I've got Sue Weaver down for this one.
Carol, hi, thank you.
Thank you, Sue.
The corner of my screen, I don't know where I am on yours. Thank you very much. Thank you very much for inviting me to update the board on some of the work that's been happening around health inequalities over recent months in Gloucestershire. But also thank you to Bren for his really good question and his really good points, because they massively, I think, set the scene for what I'd like to say around that need for us to bring some of the work together and into a more coherent whole, with some of those elements of the agenda that really do need some management around them. So, for example, looking at how we might collectively look at our impact and assure the system that we are making some progress. I also really welcome the comment around the need to focus on a bit more on some of the causes of the causes. So we know we've got the priority around housing, but also and the recommendations coming from Marmot post-COVID are absolutely the need to be really behind those wider social determinants of health and well-being. So I think the question links really well into where we need to be focusing. What I will do, if that's okay, you've all got the paper, I'm not going to attempt to share it. I'll run through some really key points from within the paper, but I particularly want to focus on some of the opportunities and recommendations to strengthen the agenda with respect to that bringing it together, bringing all of these strands and the great work together into a bit more of a coherent system to make sure that the parts are working synergistically. So I'll touch on at the end and back to the board around the recommendation to convene a panel, for want of a better word. I'd also like to ask the board for some feedback on the draft principles that we've developed for anchor institutions under that piece of work. And finally, I'd like us to have a think about in relation to that question around how we more effectively involve communities in this agenda, absolutely front and centre, and what that means in terms of the opportunity we've got in Gloucestershire alongside our selection to participate in the King's Fund Healthier Communities Together programme, and how, which I know Mary's presenting on later, but how we can bring those two aspects together, the power we're talking about, which might be responsible for some of those elements of the agenda that need to be managed, but how we can work together with that really, really exciting emergent piece of work to make sure that the community part is front and centre, and that the two are talking to one another, and how we can marry those things together. So that was a bit of a long introduction. I'll run through some key bits within the paper. I won't repeat the background information on health inequalities in Gloucestershire. Just to say, within the paper, I've provided a really inadequate snapshot, just using the indicators that Public Health England actually select for their health inequalities dashboard. So they're there for that reason, rather than they're necessarily being the ones that we would be choosing under our health and wellbeing board priorities. But they do give us a snapshot, and the snapshot suggests no significant change over the last decade, or modest improvement, which feels a bit damp. And also outstanding is that indicator around reception year obesity. And although we're very mindful and conscious of that being an area of need, it is a priority. It's a huge area of inequality. We do also know that the data from this year on which that indicator was measured is probably a bit wobbly, because we stopped measuring kids last March when we shut the schools. What we do need, and this was alluded to at the end, in terms of then one of the things that the panel would need to have some oversight taking forward would be that deeper dive that we will need in terms of the health inequalities linked to each of the Health and Wellbeing Board strategic priority areas. And that will then collectively give us a richer dashboard and means of monitoring our progress as well. And in addition to that, there would be an opportunity to develop that more deeper understanding against those priorities of the specific impacts of COVID-19. And I used obesity there in the paper to illustrate that point, but that needs a lot more understanding around the other priorities too, and indeed around obesity. So one of the things that the paper did focus on, and I can really kind of hear Bren's point around it feeling like some sort of chunks of work rather than the whole. We've been working on one or two enablers on the health inequalities agenda, which the board has sanctioned and asked us to take forward in recent months. And they aim to build capacity within the system and to provide some hooks for the health inequalities agenda. So they might seem a little bit isolated, but their aim is to certainly help to embed a much more systematic and evidence-based approach to understanding and acting on health inequalities within the county. And these include, firstly, the Health Inequalities Toolkit. I've put a little bit of detail in the paper about that to illustrate what its intention is. And I'd liken it to something that the board will be more familiar with, and that is to some of the work that was taken forward under the ACES agenda and the ACES panel, whereby that panel developed some really usable resources for the wider system to help them adopt a more trauma-informed approach and to build resilience across the system. So what we're intending to do as part of that toolkit is to pull together some of the really inaccessible tools that are available to help us collectively understand health inequalities and direct some of our action, but to translate those into something that others can pick up and use. So to really simplify them, a lot of them are very technical tools. And so we're doing a piece of work in various areas, as illustrated in the paper, to test a number of those tools in the kind of real world and then to adapt them so that we can then ultimately share them as part of a suite of resources on health inequalities for others to be able to pick up and use to strengthen their own approach, be it at a service level, within a community, within an organisation, or what have you. I won't go into detail around the vaccine equity work. I think to say it has been our principal focus since January, which has unfortunately kind of sidelined a little bit of the other work, but you know, as it should be, because it's probably singly the most immediate and important thing we can do right now on health inequalities across our county. But also I just wanted to kind of flag up one of those silver linings linked to this this work, is that it has provided a vehicle for some really good dialogues and relationship building and asset mapping within our communities that we now need to maintain and build on. And some examples of those would be the Community Champions network, which has been supporting some of the COVID work throughout, and and there are a number of other sort of more specific examples that we can build on. Moving on to the anchor institutions piece. So we have started this work. This is so key, this piece of work, and hearing the rest of the presentations today, the opportunity here I think is phenomenal. We've started this piece of work and I've produced the principles that we'll come on to in a moment. We've also started a mapping exercise and we're just conscious of the huge amount of work that is going on under those themes, particularly around employment, training, leadership, social value, and also the level of engagement and particularly among...
I'm sharing now.
Yeah.
Okay.
Among the NHS organisations. We have now secured some dedicated capacity that's in the form of a senior manager and a facilitator from some of the COMP funding, that's the outbreak management funding, specifically to focus on health inequalities. And the Anchor Institutions work is one of the key projects that I think we would want that really be driving at pace once we've got it in place. Moving on then to the section outlining some of the things under the BAME task and finish group. I don't want to repeat the things that Sarah has already updated on, but just to really flag up the next steps and the things that the panel, that the task and finish group have flagged, that need, which Sarah's alluded to build further capacity within the BAME voluntary BCS sector, and also the need to do some more focused and tailored work on prevention of ill health among BAME communities. Now that toolkit is going to will include some tools that actually can help us to do some of that more focused work in a systematic way. And one of the pieces we're taking forward is the case study mentioned for the health equity audit, which we're doing with the Healthy Lifestyle Service, and that should pull out some of those real specific, tangible adjustments that need to be made in this area. So the final section of the paper proposes the convening by the board of a small stakeholder panel or something, but a panel for want of a better name, that would be supported by those dedicated health inequalities posts over the next 2 years. And I would see the role as providing some of that oversight and some of that assurance that Bren was talking around for the elements of this agenda that need to be organised. So that would include some of the work on the development of our dashboards and our monitoring mechanisms, our risk, looking at the balance of, we've got all of this stuff going on, but what does the balance look like across the system in terms of some of that real upstream work around some of the social determinants of health and well-being? But I would see this panel as really almost sitting as a backbone and drawing from some of the whole systems methods that have been being practiced and implemented through the Gloucestershire We Can Move work and programme. I would almost see that panel as providing a sort of backbone to the health inequalities agenda, focusing very much on some of those more those aspects that need to be managed. But wrapped around that needs to be that wider system, social movement, community element of this work. And so I think when we've seen Mary's presentation as well, it might help us think through how those two bodies can really work together. And I would ultimately see that the panel's aim would be to make itself redundant as the more emergent work linked and happening underneath the King's Fund Healthy Communities Together programme takes hold and develops and grows. I think that was pretty much what I wanted to say, other than to talk through really briefly the outline principles for anchor institutions. And having revisited these, you'll see in Appendix 2, there are 10 principles. Apologies, I've got building next door. I hope it's not too noisy. There are 10 principles focusing on areas of employment, training and development, around social value linked to procurement and more widely. Some principles very much around how we work with communities, around environment, around healthy lifestyles and health and well-being and staff and our workforce, and around leadership. And I think the next step for this, alongside the mapping, is probably to bring, once we've agreed in essence to those principles, is to really try and bring them to life and probably to start sharing some examples and developing a mechanism for sharing some examples of good practice under each of those areas collectively, and also just reflecting on what I've been hearing this morning underneath each of those principles. There's a question for me around, so what are the specific things that we could be doing under each of those with our BAME communities? But we could also go through that discipline of thinking that through for other inclusion groups and marginalised communities and other protected characteristics. So that is all I wanted to say. In terms of my questions, then it's really over to you and some thoughts on that idea of the panel, but also I'd really value some feedback on those principles.
Thank you very much, Sue, for that. I mean, the report is extensive, and I just applaud the fact you've been able to get some of the work done during the year we've had. Well done. Thank your team for us. The recommendations are only 3, but it doesn't really reflect the volume of work that you've done over each of the topic headings that you have, and in particular the anchor institution stuff with the community element and the toolkits. It's a significant piece of work, but it seems to have actually, it's the beginning of a huger piece of work that needs very specific organisational input from all members of this board. So with that in mind, can we have some notion of who'd like to ask some questions or make comment?
Chair, we have Sarah, Scott and Richard Boyle's hands up, and Mary would also like to make a comment.
Thank you very much. Can we go with Sarah first?
Thanks, Chair. I think I just wanted to reflect just the breadth of work that has been undertaken to try and pull the report together. I think we've been trying to direct our health and equalities work by the health and wellbeing strategy and the priorities for quite some time. And I think it's taken this piece of work for us to realise that actually we need something else. And we were talking about a health and equalities framework before COVID. So Sue's worked very closely with the CCG on this, and it's a huge amount of work. I think it's helpful. I found it helpful. You know, I know all the constituent parts of this, to have it all in one paper and to reflect that it is messy, it is difficult, and if it should be, because it's a really complex area, and then trying to weave in an approach to how we do it, how we tackle this meaningfully with our residents, again, makes it even more messy, but that's probably really healthy. Just to say thank you to Sue, really, because I think it's a really helpful starting point for us to really consider this and how we take it forward.
Thank you, Sarah. Moot points, I think. Richard.
Thanks very much, Chair. Yeah, Sue, I've read all the reports, and probably the easiest work from this report will be doing what you've just outlined, however hard that might be. The hardest piece of work is going to be getting the citizens of Gloucestershire, who are currently in the report papers we have today, 60.7% of adults in Gloucestershire are reported as being overweight or obese, actually getting them to buy into the product of what you do and become a healthier county. And I know these are strategic papers and we're not going down to the roots today, but understanding at some point, considering we've been doing it for a number of years, not just in this county, but across the country, how you actually, as Gloucestershire County Council and a health offering, really impact and reduce obesity. I read in the papers this morning that a third of people during COVID have put weight on, a third have lost weight. But how do we make every single person in Gloucestershire really understand that if they want to live a healthier life, then tackling their own weight is the first thing that they need to do? And that, I think, is going to be the most difficult challenge that you face.
Thanks, Richard. Yeah, it is an incredible challenge, and I would also reflect that underneath that third who we think might have gained weight, that third who might have lost weight, and that third who might have stayed similar, that undoubtedly those ones that will have struggled more will be, you know, among the same population groups who are already facing the greatest challenges for other reasons. It's incredibly difficult. With the healthy weight agenda, it really has to come back to the causes of the causes. And there are two really key aspects of this agenda. And one around the prevention agenda is certainly around how we create healthier settings and environments that really help people to adopt healthier lifestyles. And that is easier said than done. We need to create environments and settings whereby the healthier option is the default or the easier option, because we know that human behaviour tends to take the course of least resistance naturally, but alongside that, of course, we do need the right support at the right time for those people that are struggling. One of the things we are working on at the moment, again jointly with the CCG, is the piece of work we're doing with busybodies in Gloucester City and the Forest of Dean, which is working really closely with families most affected by obesity to try and understand what they need. And the feedback that they have given us has been quite astonishing. Well, it hasn't been astonishing. It's been actually really it's really is a no-brainer. But families are telling us, you know, we need support around managing budgets, around parenting, around managing child's behaviour, around food planning, around food accessibility, availability of a healthy diet, affordability, and so on. And we're dealing with, we've been working with some really, really complex families to understand some of the things that they need before they are even in a place where they can begin to think about behaviour change, and that complex process of changing behaviour within an environment that's encouraging you to do the opposite. And so that insight, which I'm very, very happy actually to bring back and present to the board on another occasion, is absolutely underpinning our approach to both prevention and to management of weight. It's a good question.
Mm-hmm. Thank you, Sue. Thank you, Richard. Mary, you wanted to come in at this point?
Yeah, I just wanted to make a couple of comments. First of all, the health inequalities toolkits are really useful, and people are seeing clearly how they can be used and how they can help them to shape their work. I suppose I'd make a plea for some pace in this work. We've talked about anchor institutions for quite a while, and we need to think about, how there is some work ongoing already which will tie into this. So, for example, and colleagues be aware of this, there's a very significant piece of work on volunteering for Gloucestershire happening, working with the voluntary sector and a whole range of other partners, which will give us something that we can actually enable people who want to volunteer to fit into a structure in Gloucestershire and know where the opportunities are. It's not finished yet. It'll take another couple of months to finish, I think, but it will be there for us then to build on. I think there will be a number of pieces of work that have to continue as we develop our thinking on this, because we almost need to see some change on the ground as a board and be able to own some of that if we're to get the courage and commitment, I think, to keep going. And this will need some resourcing as we move forward. So I suppose I would challenge us to be ambitious in this area, and all of us need to work together to ensure that we hold each other to account on this.
Yeah, hear, Mary. Well said.
Yeah, I agree. Anyone else who particularly wants to make comment at the moment?
Chair, we have Chris Spencer, Chris Briley and Sarah would like to come in as well.
Okay, Chris Spencer.
Thank you, Chair. It's just, I want to put on my children's services hat just for a minute and take that narrow perspective. I think this is a great report and it's got a lot within it to be commended, but my worry is that, again, children don't feature significantly in this report. And listening to Viv Bennett, the chief nurse for England, speaking just 2 weeks ago, she was making a very strong point that history will show that the group most affected by COVID will be children and young people. And so my plea is really that we refocus a little and include children as a higher priority in thinking about inequality, because they are the future and they will be the cohort most affected, I think. I believe in what the church was saying. It's a much neglected cohort.
Can I come back on that, Karen?
So it's not really a question, it's really a plea and a statement.
It's a statement well made. Thank you for making it, Chris. Sue, did you want to respond to that?
Really briefly, yes, it's absolutely central. I was rereading yesterday the Marmot post-COVID report, and it absolutely reiterates that best start in life and the need to focus there, and that piece I would see as being taken forward under that Health and Wellbeing Board priority. But you're right, it needs to be threaded throughout the whole as well. It can't stand here. So it's really helpful, really helpful comment. Thank you.
Thank you. Chris Brearley.
Thank you, Carol. And just Chris has stolen my thunder. But we had the Tick Plus report out, I think it was last week, which was some really shocking things in there. You know, kids as young as 9 contemplating suicide in our county. And I just reiterate Chris's point, it has to be fundamental in tackling inequalities that we running through it is the voice of the young person as well. There was a great event, I think it was yesterday evening, child friendly, and Bishop Rachel chair with hundreds, I think there's over 100 people there, delegates as well as young voices. And I just think they are our future and they have to be included. And alongside that, how do we get it? And I think Rich Boyle's mentioned it, is how does it get out of this group and this board? We're just one board of, very white people and very, middle-aged, dare I say it. We're a certain age and demographics. Sorry, people, but we are. So how do we make sure that hits the wider population? And we need to do that. It fits in with Gloucestershire 2050, it's about the future of this county. So we just need to make sure we're joining those dots and we're linking in with all the good work that's taking place in our county. Because I know on the chat, Mary's talked about the work within the ICS. Mary's team are doing some amazing work. We just need to really shout about it and link in as much as possible.
I agree.
Yeah.
I fully agree with the comments just made. I mean, I think one of the initiatives that have come through the COVID period we've been through and are in at the moment is the very appropriate use of social media to contact people. Before this year, although we dabbled, we didn't use it as a primary means of communication. And I think we really have to investigate how we can do that more specifically and more widely to encompass everybody in our community, not only from the point of view of what services we offer, but actually generating the services in the first place. Real influence needs to be from the bottom up. Certainly my mantra. Sarah, did you want to come in at that point?
Yes, please. I think lots of really valid points. I think we need to remind ourselves of our Health and Wellbeing Board priorities, one of which is the best start in life. So we are focusing on children and young people. I think what we've tried to do today, in our last meeting, we talked about the 7 priorities. And we tried to tease out where inequalities were rippling through those 7 priorities. And we had planned a workshop for November, but we cancelled it because of COVID, and we were all focusing on the response. And the purpose of today really was to try and pull together all the work that's happening around inequalities. And I say it's really messy, but this needs to ripple through our 7 priorities. So we are doing some work on children. I mean, Chris, if you want to nominate a member of staff to work with us to dedicate to this priority, we would very much welcome that. Mental health is one of our priorities. It's complicated and it's messy. And we join up as much as we should? Probably not. But I think a lot of this has to be driven by our communities in terms of what they want rather than us imposing things. But I actually wanted to comment on Rich Balls's point. The solution to tackling obesity is the whole systems approach, which is our healthy weight approach, which is something we still don't have any funding for at all. And we'll come on to that later, but we don't have any funding for that. We haven't been able to find any in the county council for the last 8 years. And that's an uncomfortable truth. So if we want to be really, really, really committed to tackling the 7 priorities that we have identified as a board, we as a board need to find the resource to do that. And the whole systems approach to obesity will do exactly what Sue said. It will tackle the causes of the causes, and it will help people get to a healthy weight and maintain it, and cope with all those other influences on their weight. It's not just about getting people to go to a weight management program and get them to lose weight. We've got a reasonably successful way of doing that. We know managing weight and all the things that go with it is just so much more complicated. So it's a bit of a plea really that we think about that in the round and think about the funding as well.
Points well made, Sarah.
Chair, we have Mary would like to comment and Chris Spencer would like to come back.
Okay, Mary?
Yes, I think I would like to say, of course, a lot of our partners, there's quite a lot of work ongoing with children, and maybe we need to spell out some of this work. You know, I can think of 10 projects working with children and families, and we're particularly working with voluntary sector organisations as well to really understand their reach into communities. There's a huge amount of work, of course, underway on mental health, particularly for children and young people. And we will be picking up this with Child Friendly Gloucestershire as we work together. So perhaps we aren't sharing enough of the work we're doing, but certainly there is a lot of work underway with children. We're starting the work. We're not waiting until we set up all of the different groups to oversee the work. We're just getting on with some of the work as we go. So definitely happy at a future meeting to talk about some of the things that are underway, if that helps.
Thank you, Mary. Certainly an action point I'd like to pick on in relation to all of the work that organisations are doing that will fit into one of the 7 priorities that we have. So the existing work and the optimism for future work would be useful to identify. Chris?
Yes, just to come back on Sarah and Mary's point, really.
Nobody's denying that we don't give children a focus. But this paper is about inequality, and children do suffer inequality. That's the point I'm making. And you can cut inequality by skin colour, culture, gender. You can also cut it by age. And the point I'm making is that when it comes to inequalities, children are often overlooked. So I'm more than aware of what our priorities are in the Health and Wellbeing Board. You know, I've been a member of it now for 3 years. And I'm aware of what we're doing around children. So the point I'm making really is that in the case of inequality, children hasn't featured sufficiently in my view. That's the point I was trying to make, really, Chair.
Yeah. A point well made and very well articulated. Certainly hits a resonance with me, and it's not lost, but I think it's not as prominent in papers as perhaps we should make it. Thank you. Any further comments on this?
I didn't know whether Sarah wants to come back in or whether her hand's still up from before. No, she doesn't want to come back in.
No, okay. Thank you, Andrea. The paper itself is complex and brief in some areas. It looks at work that's been done so far and where we're going next. And on the title page, we have recommendations to board. So I just want to get a feel for how members of the board are feeling about, 1, accepting the paper, and 2, agreeing the recommendations that we have on page 41. So there are 3 recommendations there. 1 is to consider the developing programme of work on health inequalities including opportunities and recommendations to strengthen this work. 2, support the recommendation to convene a health inequalities panel to steer this agenda, supported by the Contain Outbreak Management Fund with inequalities posts. And 3, to comment on the draft principles of an anchor institution's approach to Gloucestershire. Now, I can't see members on the panel of the board, but I'd like some notion about agreeing whether the board actually agrees in principle to those recommendations. So I've got thumbs up from a lot of people. I've got nods from ones I can see. I don't have any dissent. So thank you, guys. Lots of thumbs up. And I'll put mine as well. Andrea?
Can I make a suggestion that as time goes on and when board members leave the meeting, they might get some ideas and some thoughts about the draft principles, that if anything does spring to mind, that if they email into me and I will forward them on to Sue. That would be really helpful. Thank you for that intervention, Andrea. So given the feedback we've had in terms of the recommendations, then I make the statement that the board has agreed to the recommendations, with the caveat on 3 that members are still available, can still inform what we take forward by responding to Andrea, particularly about the anchor institutions and the 10 principles stated. Okay, thank you very much.
Thank you.
Thank you, Sue. Right, we move on to item 9 of the agenda, funding update. This is for me. I just want to draw members' attention to where we are at with funding. In October, I communicated an email on behalf of the board to actually get some notion of how individual organisations could contribute to funding for the work that's enshrined in the Health and Wellbeing Board that largely they're taking responsibility for in terms of the 7 priorities. We were due to have the workshop to flesh out what this all means in November, but we had to cancel that. I sent out a further email just as a prompt, and we've had some response back to that. In all of this period, we've had contact with governance to actually ascertain that the Health and Wellbeing Board itself hasn't got an executive function in terms of holding a budget, so we are not able to hold it. So it's very much a matter of actually looking at aligning a budget within member organisations to follow through on some work. We've had pledges through, which I won't go into, but the general principle is that to actually continue with some of the work that the Health and Wellbeing Board has agreed to do, that we do need seed funds and funds available to do that. So I raised the issue about funding. It's difficult in families and it's also difficult in partners to actually look at that, given we've all got very significant impact on our budgets. But to enable this work to go forward, we need to have a consideration about how we're going to resource the work to be done. I invite Sarah in at that point if you want to add anything, Sarah.
No, just to say that at the moment there isn't any funding to continue the healthy weight work other than what's already been committed for treatment services. So we need to be mindful in terms of what we're reporting back, because if we can't get the programme of work started, then that's obviously going to be a bit of a problem. And we could look at that from a public health perspective in terms of what we could bid for from funds going forward from GCC. But it's just whether as a board we want to think about if we are willing to support the 7 priorities financially, because otherwise there's no point, is there? If we can't find the money, if we genuinely can't as a board, well then I think we might have to pare back on what we expect from that particular priority.
I wonder, can I make a comment on this? It would be helpful if we share the areas where we need funding and what the funding exactly is for, because I do know colleagues have stepped forward to fund, we can move together across this board, which has been really positive. So if there are other areas that are specific, let's consider them together and see if we can actually fund them. I think this is a time to be ambitious and to move forward. And we need to understand the scale of funding. Of course, if it's millions of pounds, that's slightly different. We'll have to think about it carefully. But let's try and see what we can put together.
I think that's a helpful comment, Mary. It's just how we do that. Any thoughts, Sarah, on how we actually get together as a collective and look out cost and function and benefit?
The papers that went to board in September did talk about indicative levels of funding in terms of what we thought we might need for a whole systems approach and what the ACES approach would need. I think we probably have secured sufficient funding now for the We Can Move physical activity social movement, which is really positive, and that's the delivery vehicle, if you like, for our physical activity priority. So I think the work was there to give members an indication. We did talk through that. We can pick that up again to have a look at that. But fundamentally, we would need a resource to take forward a whole systems approach to obesity. It needs to be recurrent because this is about sustainable change, working with communities. So we can't just dip in and out year on year. We need to be able to be certain of the funding. The ACES work, we've managed to find the money between Chris's team and my team to continue the ACES practitioner. And we're working with some of the community organisations to try and source some extra funding. But it is still run on a shoestring, and we have achieved quite a lot on a shoestring, but we need to think that through. So perhaps then there's an ask. I think it's Rhiannon who is the lead for ACES now, and I'm the lead for Healthy Weight, to take that away and come back with an ask of the board.
I think clarity would be helpful, Sarah, because as Mary rightly says, it's difficult to work out how to accord even the smallest amount of budget. I mean, we are a lot of membership. If everyone contributes a small amount, then we've got a significant amount to go forward and actually make some real difference. So if Sarah would pick that up as an action point, that would be helpful. And my suggestion would it needs to be done fairly soon. You can add it to your list of many things to do, Sarah. Thank you.
Happy to do that.
Thank you very much. Mary, does that help? We can get some actual numbers together and actually look at costs of particularly in interventions in relation to the 7 priorities. Yeah, okay. General agreement there. Thank you very much. And I would just like to say thank you very much for all of the effort and commitment in terms of funding. Even those organisations who have not been able to fund, they've certainly worked quite hard to actually mitigate, if not funding, action. So thank you very much for that. We now move on to item 10 on the agenda, King's Fund Healthier Communities, and that's for Mary.
Thank you, Chair. I'll just get the slides. Sorry, just let me. Okay, can everybody see that? Yes? Okay, so this is ending the meeting with some good news, actually. There's a programme called the Healthy Communities Together programme, and we have been successful in being approved to be part of that programme. It's very much part of the work we'll be doing to learn about how we approach working on health inequalities. So I just want to share with you some of the elements of that programme and our approach to date. So just to mention, first of all, we do have in the system the Enabling Active Communities Partnership, and we have everybody around the table, the police, the PCC, the district and the VCSE, and some large statutory, voluntary sector organisations represented there. It's a very high energy group. Anna Brinkoff is the joint chair, and she's brought some new thinking to that, so we're very grateful for that. And it's been in existence since 2015, but has developed a lot and has begun to work with the prevention and self-care as well. And so public health are very involved and will become more involved now. And the aim is to improve health and wellbeing through mobilising assets within communities and increasing people's control over their health and lives. So it is a very exciting meeting. It meets every other month and it is making progress. So we then saw this opportunity, which is Healthy Communities Together, where the King's Fund and the National Lottery have been working together, and the aim is to put together this programme, which is to build genuine partnership work in local areas between the voluntary sector, NHS, local authorities and other partners. And there was quite a lot of money attached to this, and there were 275 applications, reduced to 40 and then 10. And we were delighted that we were one of the 10 selected. And that was really, it's really a credit to a lot of the people who worked on this, because obviously Gloucestershire has significant areas of inequality, but overall we appear to be an area that doesn't have significant overall inequality issues. So we therefore felt that we were definitely punching above our weight to get accepted for this. So the programme has 50,000 in the year one and 450,000 then development support for up to 3 years. And that's really we want to be part of it, because we could do the learning with the others as we work through. And you'll see that some of those other areas are very significant areas of inequality. So we want to think about whole system change, and this will not be the only thing we'll do, but it will give us some sort of a structure to work together on tackling inequalities and look at this way of putting together some transformative change and work together across statutory VCSE and communities across the county. And the programme will have a whole methodology which we'll be able to understand, which is and it will be very much aligned with what Sue has already shared, in fact. But there'll be people and resources attached to it, which will help us, because as you can see, we are quite stretched already in Gloucestershire with all of the different priorities. So we'll have some opportunity to widen the discussion, deepen our understanding, test those tools I already referred to, which are already developed by our public health team, but are really, really useful. And then obviously developing action, which should be absolutely key, because this will be monitored and there will be expectation that there will be change. And then obviously sharing the learning and understanding the impact. So just to say, the bid racing team, I thought I'd give them, name them here, because they've been really good and they've got on with the work. But we will have then our other partners, enabling national communities, who are here today, part of that project. Barnwood Trust have very kindly agreed to be the fund holding organisation on behalf of the partners, and the work has started then to design and map out the work. So this is the last slide, and it's probably difficult to read, but its primary focus is widening the discussion, deepening the understanding, and then we'll begin to develop the approach and develop the action plan and understand how we apply that funding that we've been offered for Gloucestershire for the next 3 years. So it's really good news. It's a really good chance to take this programme forward alongside all of the other work we'll be doing, and to challenge ourselves and to learn from it. So that's it in a nutshell. Happy to take any questions, and as I said, other partners will be working on this as well.
Yeah. I think from my perspective, it's very action centred. It's about achieving stuff, and it's about engaging with the whole of the community in Gloucestershire. I think it's an excellent piece of work. Congratulations to everybody. Really well done. Right. Andrea, do we have anyone who is indicating they want to make comment?
No, we don't, Chair.
No. Amazing. Well, blasted into silence by some really, really positive news. Well done. Well done. Right.
Oh, sorry, Chair. Spoke too soon. Chris Spencer would like to comment.
Chris.
Yeah, and you know what I'm going to say, don't you?
I do.
Because
please say it.
Because activity and exercise is a habit, and it starts at a young age, and therefore it's another plea on top of a common theme, which is this is a significant achievement in securing this funding, and it's well done to Mary and her staff for doing that. Again, my plea is to make certain that young people are involved in whatever programme we do develop going forward.
Well stated, Chris. Thank you. Mary, do you want to make any comment on that?
I mean, absolutely. I would expect that there'll be a huge amount of learning to build in. I just want to say that I wouldn't like the NHS to take any of the credit for this. This is a wider partnership work. As you can see, BAME will be holding the funding. So I think, and I personally haven't had a lot to do with the writing of this. I just was really encouraging people to take it forward. So it would be really interesting to see. And I think, Chris, we'll have a chance for you or one of your team as well, just to join in with this and think, how can we, I suspect there'll be a huge amount of pressure to deliver action from this programme because it's a national programme and a lot of people will be watching it carefully. So it should be a good chance for us to work together on this. But I just want to be clear, I don't want to take the credit for this, it's other people's credit.
Yeah, point well made, Mary. I think, you know, your grouping is going to expand by at least one member directly representing child and family. Thank you very much for making the point, Chris, and thank you for your response, Mary. I think the whole ethos within Gloucestershire is one of partnership and working together, and I'm really pleased about the membership of this group, which is so generic, really. Covers all the bases and will soon cover directly children's. I think that brings us to the end of our agenda, so thank you very much for finishing on that really optimistic note. I would just like to make a personal thanks to members of the Health and Wellbeing Board. I've been chair since January last year, and we're moving towards an end of term and an election phase. So I just wanted to thank members of the board, members of the support staff, Democratic Services Unit, and all of the officers for their support during this year. And for the work that I can envisage going forward. So thank you very much for your time. I therefore close the meeting.